Hi, I'm Eleni Josua,
And I'm Heather Huddleston.
and we're so grateful for your interest in the ASPIRE study, assessing the safety of pregnancy in the coronavirus pandemic. The purpose of this presentation is to tell you a little bit more about the study background, rationale, and design. As you all know, as of December of 2019, a novel, highly infectious coronavirus known as SARS-CoV-2 was first noted in Wuhan, China. In the United States, community spread was documented by February of 2020. By May 13th, the virus has struck over 4 million confirmed cases globally and continues to spread. The emergence of this highly infectious and novel virus has raised really important questions for pregnancy. As reproductive biologists and endocrinologists, we're invested in figuring out what the implications are of this virus in pregnancy. What we know so far is that viral infections in general can adversely affect fetal development. Epidemiologic studies from historic viral outbreaks of diseases like varicella, rubella, and influenza have been associated with increased risks of miscarriage, birth defects, and long-term neuropsychiatric disorders such as autism, ADHD, and schizophrenia. Effects on developing fetuses can vary by trimester of exposure. The first trimester is a really unique period of pregnancy because it's the time during which all of the organ systems form. This is organogenesis. Importantly, the placenta also becomes established in the first trimester, which dictates the trajectory of ongoing fetal growth and development. The first trimester, when you get infected in the first trimester, there have been characteristic congenital malformations or birth defects, as well as severe neurologic outcomes for other viruses like CMV and Zika. Of course, infection later on in pregnancy can still cause adverse outcomes for mom and baby, such as severe maternal illness, issues with growth, and preterm delivery. There are 3 discrete mechanisms by which viruses can injure developing fetuses. The virus can directly infect the fetus itself, such as the case with Zika, but even in the absence of vertical transmission of an infectious virus from mom to baby, there can be really severe consequences of viral infection during pregnancy. By infecting tissues like the placenta and decidua at the maternal-fetal interface, viruses can adversely impact fetal development. Finally, even just with maternal inflammatory responses as a result of viral injury, this can predispose to a pretty hostile environment for fetal development and is especially damaging for neurogenesis in babies. Examples of viruses that directly infect fetuses are the torch pathogens as well as Zika. By directly infecting developing babies, these cause characteristic birth defects like microcephaly and problems with behavioral and psychiatric disorders. Viruses that infect the decidua and placenta also predispose to issues with growth and impairments in neurodevelopment, as well as increased risk of pregnancy loss. Maternal immune-mediated responses of maternal infection, even in absence of infecting the baby or placenta, can cause problems with fetal development. There are powerful animal models which show maternal inflammation affects neurogenesis of the fetus, and further, at the epidemiologic literature previously cited has shown increased risks of miscarriage, birth defects, and neuropsychiatric problems in babies who developed while mothers had infections. Importantly, pregnancy is not an on-off switch with regards to immunology. There's a dynamic and characteristic alteration of sequenced events over the course of pregnancy in the immune response. The first trimester is characterized by a Th1 predominant pro-inflammatory response, which is requisite for appropriate implantation and the onset of pregnancy. This shifts to a Th2 type response in the second trimester, which is important for fetal growth. In the third trimester, the immune response again shifts to a predominantly Th1 type response with pro-inflammation required for the onset of labor and delivery. So, should we worry about this virus, the novel coronavirus, and pregnancy? Possibly. We've just discussed several potential pathways by which this virus infection with coronavirus can, especially with exposures in the first trimester, might lead to adverse pregnancy outcomes. Furthermore, we know this virus is not behaving like anything we've ever seen before. It's not just a lung respiratory pathogen. It has caused injury to all sorts of tissue, such as the blood, the brain, the kidneys, the liver, the endothelium, and the placenta might also be on this list. Finally, the mechanisms of injury from coronavirus include cytokine storm and significant coagulopathy with presence of antiphospholipid antibodies in some, which we know are hostile for fetal development and may predispose to increased risk of growth restriction by impacting the placenta or even miscarriage in the first trimester. But rather than worry, we should inform ourselves by actual data. It's really important to get this information to answer these critical questions. Recently, a case report of a 28-year-old showed a proof of concept that the virus can infect the placenta and may predispose to miscarriage. And there was a recent study using electron microscopy which did show virus directly invading the human placenta. Whether these are 1 in a million or more common is not yet known, but the proof of concept has been established. The Society for Assisted Reproductive Technology is uniquely positioned because of our access to pregnancy early on. Traditionally, most women in the United States, at least, don't get in with their obstetrician until about 10 or 12 weeks of pregnancy, which is past this critical window of fetal development. Often women won't even realize they're pregnant until midway through the first trimester, and this limits the ability to assess precisely gestational dating. Finally, first trimester miscarriages most commonly occur before initiating obstetric care, which limits our ability to capture these important pregnancy outcomes. By taking care of women on their fertility journey and in their very early pregnancy through early ultrasounds and blood tests, we can unlock this critical window of pregnancy development for women everywhere to understand what, if any, are the implications of coronavirus infection early on in pregnancy. And we will switch over now to Dr. Heather Huddleston, who'll tell you a little bit more about the study design.
Okay. All right, everybody. So I am going to talk more about the study design and a little bit about just the mechanics of the study. We know that some of the people watching this presentation are hopefully partners with us in helping us recruit patients. So we want to make sure everyone's sort of up to speed and understanding what are the procedures that the patients will be going through. So first, let's just talk about what is the best way to answer some of these urgent questions that pregnant women have or women who are thinking about getting pregnant might have. As Dr. Jaswal said, there is a question around what are the actual risks of exposure to this virus during the first trimester? And if there is a risk, what is the magnitude of that risk? Could exposure to the virus during the first trimester cause miscarriage or other outcomes that are specific to the first trimester and therefore often not tracked in these later pregnancy studies? And are there risks associated with asymptomatic COVID-19? As we know that many women will potentially contract this virus but not have symptoms. There are several registry-based studies that have hit the ground and are attempting to answer some very urgent questions around this virus and pregnancy. But in terms of some of these questions that are listed, they may not be the optimal study design. And that is because they lack appropriate controls. There can be referral bias. There can be difficulty recruiting women in the first trimester. And the inability to consider asymptomatic infection. So we were very interested in thinking about ways that we could design a study to answer some of the questions that we were most interested in. So this is just a real basic study to talk a little bit about what a prospective study does and how it does it. So in the ASPIRE study, and like other prospective birth cohort type studies, women at the time of positive pregnancy test become eligible. And so that's the point at which they would enroll. By detecting who might carry antibodies for COVID-19 at the very beginning of enrollment, we are able to detect the prevalence of prior infection in that cohort. And then by tracking conversion or the acquiring antibodies to the infection or to SARS-CoV-2 at various time points over pregnancy, we're able to then estimate the incidence of viral infection, and we're able to link it to the time point at which viral infection occurred. The goal is really just at the end of the study, once we take stock of the patients who've acquired the virus, we're able to look at the exposed patients and the unexposed patients. And then we're able to look at what are the outcomes of interest and did they differ across the exposed versus the unexposed group. So that's a basic premise of a prospective cohort study. And that's what we adopted as we designed ASPIRE. So ASPIRE is a prospective cohort study of newly pregnant women recruited from across the US. And one of the sort of key things that we wanted to do was to determine what are the adverse maternal and fetal outcomes of infection with this virus, particularly when exposure occurs during the first trimester, this very hard to study time point. Now, we wanted to make eligible for the study any pregnant women between 4 and 10 weeks of gestation, but we also wanted to leverage the SART clinics as a kind of key partner, because we know that these clinics take care of women at these very early stages of pregnancy and therefore can help with recruiting women at a time that we've not historically been able to recruit women. So this is a little bit about sort of the general design of the study. So we are thinking about using as a main source of population the SART clinics. So we know that these clinics take care of, we estimate, around 100,000 pregnancies per year. There's about 70,000 IVF pregnancies, but we know that these clinics take care of many other pregnancies. These clinics will help us by engaging with patients and letting them know about the existence of the study. So we're not asking our SART clinic partners to actually recruit the patients or sign consents, but we want them to let the patients know about the study so that patients can opt in if they are interested. Patients will make the connection with the ASPIRE study by going to our website, and by the website, they're able to then enroll and proceed with signing of consents and things like this. We also are planning to enroll pregnancies that are spontaneous that didn't occur in SART centers. So these will be community recruited women who may learn about the study either from friends or their OBGYN or social media. And these women, if they have regular cycles and feel confident about their pregnancy dating and are less than 10 weeks gestation, can also be enrolled in the study. We're hoping that this will be around 1/3 of the study population and will give us access to a slightly more generalizable population. So now let's just talk about what the study patients are going to be doing. So this is a schematic that shows the timeline of that we're going to be following these patients. So first trimester, second trimester, third trimester, and then delivery, and then post-delivery. So at enrollment, this is going to occur between 4 and 10 weeks. Next is we are going to be tracking women throughout their pregnancy with serosurveillance. So we are asking women to provide blood spots on cards that they'll mail back to us at various time points, and that's going to allow us to track antibodies to the virus and when they actually present themselves in our population of interest. We are going to have a more aggressive screening protocol during the first trimester because of its highly important nature for fetal development, but we will continue monthly screening. So we'll do weekly screenings with blood cards in the first trimester, but monthly thereafter. We'll also do symptom tracking, again, much more aggressively in the first trimester, but we'll continue with weekly throughout the study. And then we'll be getting patient-reported measures and outcomes, so things like asking the patient about their demographics, their stress levels, their behaviors, their medications, pre and post-pregnant, or pre and during pregnancy, and then also being able to get measures around the delivery and the newborn experience. We'll be collecting medical records and able to look at both verifying things around first trimester or second trimester care, but also around the delivery and around the child development. Our hope is to also do some collections through biobanking. So this is an area that we're still developing, and we'll be looking for partners within our clinics network to help with this. And then importantly, we'll be looking at child development. So we have collaborators in neonatology, and they are helping us to design ways that we will be able to ascertain child development across multiple areas, and we'll be planning to do this at least from through 18 months of the child's life. So that's a lot of information, but that's just the big picture of what we're trying to collect out of this study, so that again, we can look at, does infection with the coronavirus during pregnancy at any given time lead to or is more associated with higher risks for the pregnancy, for the obstetric outcomes, or for child development. The types of procedures that we're talking about here, so as I said, there's these blood spot kits that we're going to use to collect blood that will then be sent back to us and then later tested for antibodies to the coronavirus. We will be asking patients to do surveys during their pregnancy to collect the patient-reported outcomes. And then many of these will be able to be done on the phone, longer surveys, potentially on the computer. And then, as I said, during the child's development, there is a validated questionnaire that we'll be using to survey developmental milestones. And that, again, is also an electronic survey. Enrollment mechanics. So for our SART centers that are working with us, we want you to know that there's a website that we've built as a website that will hopefully take all of the work off of your plates and allow patients to engage with the study directly, learn about the study, all of the requirements of the study, frequently asked questions, and then to enroll and proceed with consent and enrollment through this website. Patients can learn about what's involved with the study on that website. We have a list of frequently asked questions. We also have a short video that walks patients through what they would be signing up for when they sign up for the study. And so you're welcome to take a look there to also see what your patients might be seeing if they enroll. So as of May 12th, I'm excited to just say that we already have 63 partner clinics, and this is something that we think will be ongoing over the next several weeks, but we are just thrilled to have this outpouring of support and excitement about participating in this study from the centers listed here. And these centers are all listed on our website, and we're constantly updating them as we get new partners. So we are very excited to partner with anyone who's interested in helping us with the study, whether it's our clinical partners who are helping recruit, whether it's patients who are interested, or early pregnant women who are interested in participating, or if you're looking for ways to help and are interested in helping find funding or participate in our funding initiative. These are all ways that we can contribute to the goal of answering questions that we think are very important to ask and answer for families across the world. So with that, I think that is where we will close, but we are looking forward to continuing the dialogue and continuing to learn more about this virus with your help.
Thanks again.
Thanks so much.